I guess I've been licensed as a mental health professional for about 35 years now. And I've been around the neurobiofeedback universe for at least 30 years. Long enough that I know a lot of the principles, the guys who sort of brought it from research to where people in clinics can be using it to help their patients, to help their clients. Eugene Peniston from the Menninger Foundation, I did a lot of training with him back in the day, back in Kansas, and enjoyed time with him. I guess I first really started in the field, started with a meeting at a CHAD meeting. I was working at a hospital. I was in hospital administration, and I ran in an inpatient setting. I ran a children's psychiatric unit, a teenage adolescent psychiatric unit, and an adolescent chemical dependency unit, and a day treatment program, and had a fairly big area of responsibility. And at night, I ran a support group for parents with ADHD kids, a CHAD group. And there were about 120 parents this one night, and I did my lecture, whatever it was I was talking about at the time, medications or school interventions or whatever it might be. And one of the parents stood up. I knew her and liked her, and she stood up and she said, "Hey, Doug, what do you think about this treatment for ADHD that was on TV out of Los Angeles last night called brainwave biofeedback treatment?" And in front of all these parents, I said, it doesn't work. And she said, how do you know it doesn't work? And I actually said this, because I know everything there is to know about the treatment of ADHD, and I don't know anything about that, so it doesn't work. And what she said next really changed sort of the course of my professional life at that point. She said, "Doug, we love you, but your ignorance of the subject does not make you an expert in that subject." And so I had to confess she was right, and apologized to everybody. And the very next day I picked up the phone and I called the man who had been on TV the night before. His name was Siegfried Othmer, and he and his wife Susan had moved out from back east to Los Angeles, and were really moving the field of brainwave biofeedback as a treatment that could be done in a clinical practice, moving it forward. Siegfried was a physics professor at a university back east, and Susan was a nurse, and it had really helped. Their son, Barry Sturman, was doing research with brainwave biofeedback to help people with seizure disorders and teach them how to not have seizures. And so that mattered to their family tremendously, and it helped their son a great deal. So they moved out to Los Angeles. And because Siegfried was a physicist, he was really good at understanding this whole field of brainwaves and the physics of it, and how to get the feedback to the client fast enough that they could learn to change and control their own brainwave activity. And then he was smart enough to be able to get the right software engineers in and turn it into video games that any client of any age, 6 years old and up, could play and learn how to change and control their own brainwaves. So Siegfried heard my story and he said, "Come on down and let's have lunch." So I went down to LA and met with him, and he said, "I have a training next week. Why don't you come and see if this is for you?" And I did. And it was spectacular. It really helped. It helped about 70% of my private clients learn how to change and control their brainwave activity. It was really good. And that was way back in the day. That was almost 30 years ago. Then, after I was working in that field, I was at a seminar in Palm Springs, and I met a man named Len Oakes. He was doing a workshop there on a new technology that he was developing, where he was putting together what you would find on Amazon now as sound and light machines, little flickering lights and little things that go boop, boop, boop in your ears. And he was taking the brainwave biofeedback amplifier and systems and marrying them to the stimulation from the glasses. So it seemed fascinating to me because it was taking learning, operant learning, out of the loop here. It was the person's brain driving the feedback that came back through little flickering glasses. It's called the Flexix system, and I asked if I could be a part of their team collecting data for the FDA, and another month later, and I had a system and I was collecting data for the team. And it was very, very powerful. I was using it in addition to the traditional neurofeedback systems. I had 2 traditional neurofeedback systems, had a technician that was helping me with my clients, and then we got a Flexix system, and it worked really well, especially the more difficult that a case was. It seemed to help a lot, doing things that were unpredictable. Like I wouldn't have anticipated how much it could have helped somebody who had significant brain injury from an auto accident or so on. So anyway, it was great. So time went on, and working with that Flexix system, Dr. Oakes called and said, hey, we noticed that less is more. So what we'd like you to do is to put some electrical tape over the lights, the LEDs that would flicker, so the light's indirect, and turn the lights way down. So we did, and the amount of flicker from the lights, I mean the intensity of the light was greatly reduced. We got the same great results. Same results. So another few weeks or a month went by, and he called again, and he said, you know, I want you to put some cardboard over the LEDs, so just the photons go through. And so, okay, so we used that with our clients with some cardboard over the lights. Got the same great results. Then he said, okay, now I want you to put the glasses on the table with the cardboard on them in front of your patient. And I just kind of said, I'm not going to do that. That doesn't seem to make any sense to me. And there were some other people that he was working with who said, we know something really significant is happening here. We just aren't sure what it is. And funded him to be able to take the system to the Livermore labs near where he lived. And what they determined was it wasn't the glasses, it was the little electric impulse coming from the amplifier through the wire to the glasses. The brain was picking that up in an insulated wire, that little tiny electric impulse driven from the person's own brainwaves, but offset slightly from their dominant brainwave. So they cut off the glasses, threw them away. And for a time, then the system just had the wire laying over somebody's shoulder. And fast forward now to today, we have the system that we have now. It's the grandson of that original Flexix system that I was part of the research team so many years ago. This system today is much simpler, more elegant, more efficient, and is something that I'd really like to share with you. If you're interested in all of what we're doing, you're going to look to find out more about the world of neurofeedback. And you're going to find that, for instance, on YouTube, there are like 460,000 videos on brainwave biofeedback or neurofeedback, different technologies. There's a lot out there. And I have seen in the last 30 years this field just grow, just explode. There are neurofeedback systems using infrared sensors like the Mendy in the $350 range. There are all kinds of other kinds of neurofeedback systems that are bands and have software that can work on your iPhone, and they are fun. They are fun in the $300 range, sometimes $500 range. And they're great for use at home. If you want to meditate better and you want to replace that morning cup of coffee with being more focused, have a little bit more self-regulation, these kinds of things are great. But when we're talking about a clinical setting where you are a licensed professional, you're a psychologist, a medical doctor, you're a chiropractor, you're a licensed marriage and family therapist or LCSW, but you are working with people with health or mental health concerns in a practice, this direct neurofeedback is exactly what you want to look for, and let me tell you why. When it comes to professional quality equipment, you're going to have a couple of different elements in this. You're going to have how long does it take for my patient, my client, to notice there's a change and to start to respond and get optimistic about the treatment. How much of an investment do they have to make first before they start to notice a change? And then, secondly, how much training does it take for me or for my technician to learn how to operate this well so that my client gets benefit out of it? Those are the two most important elements when it comes to a clinical practice, not what does it cost. Because you could save money over on this side, but when it comes to training or clients coming, which was a marketing effort to get them to come, you told them this was going to work and they come and they're there for 10 sessions and they feel nothing, then they don't come back. That's a loss. So what we want as clinicians is we want a technology that people right up front know that this is helping them. That 90% of the people who come and try direct neurofeedback notice something significant, notice something positive after the first session. And so they come back. And also a technology that is simple to train, relatively simple. I mean, it's still a medical device, but relatively simple to train, for you to be trained with it and for you to train a technician, a nurse, a biofeedback technician in how to operate it. Simple to operate, fast results. This is the combination that we're looking for in a clinical practice, and that it works, that it actually helps your patients. Direct neurofeedback is that technology you're looking for. Now, I have done a lot of traditional neurofeedback through the years, and we still use it today in our practice. Our athletes are all trained with traditional neurofeedback as well as direct neurofeedback. But when I was in solo private practice as a clinician, all I used was direct neurofeedback because my clients felt the impact immediately. 9 out of 10 of them knew at the end of the first session that something significant was happening, something positive was happening. And we got results very quickly. In traditional neurofeedback, the course is typically something like this. There may be a brain map with computer printout that the client has to invest in. And then based on that and that report, then the client begins treatment and may take 5 or 10, 15 sessions before they kind of get what they're doing, because it is operant learning. You have to learn how to do it. Now, some systems are better than others. And the system we use with athletes typically only takes a couple of hours for the athlete to sort of get what it is they're doing and how to do it. It's an excellent system, but it's very complicated. But the typical traditional neurofeedback that's sold to mental health professionals or chiropractors or medical doctors, you're looking at having to convince your patient that they're going to be there about 10 or 12 or 15 hours before they really start to notice a difference in treatment. And then it might take 30 or 40 hours of treatment before they reach their treatment goals. This is how it is. When it comes to direct neurofeedback, again, the person 9 out of 10 times notices something is changing in their brain the first session, and they'll report clarity of thought, relaxation in their neck and shoulders, warmth in their hands, a shift in the parasympathetic nervous system, perhaps better vision, these kinds of changes, less anxiety, peace, calm, focus. It's really nice to see. Some people notice it when they're in the chair. Some people notice it 2 or 3 hours later. But 9 out of 10 people will report that that first session convinced them they wanted a second session. And depending upon the diagnosis, the issue that you're treating, some people reach their treatment goals within 12 or 15 sessions. Other people, it takes a little bit longer. Somebody who's gone through the windshield of a car and had pretty traumatic brain injury, it's going to take a little bit longer than somebody with an anxiety disorder. But I've never seen anything as good as the direct neurofeedback technology. So in this video, I want to tell you why the Calm Waves direct neurofeedback, I think, is the very best thing that you can put into your clinical practice. Let me just show you. The hardware for the system has become very advanced, very simple, much smaller, portable. So you have the amplifier, that black box, that is where all the magic happens, and then 5 wires, a ground wire, 2 reference wires, and the 2 leads that we put on the forehead, and it plugs into a desktop or even a laptop computer. We'd really like you to see just how simple this all is software-wise. For once upon a time, this was a very complicated process. Now, some brilliant software writers have made this very, very simple. So we just open up the program and tell it what application we want to work with. It is this direct neurofeedback application. It opens up where we can tell it what locations we are going to put the electrodes on, but in our protocol, 9 out of 10 times, we put it right on the forehead where it's easy to put on and easy to take off and clean up later. It goes very, very quickly. Over here, we get the ohm reading where we can see how good of a connection that we have and make sure that it's a good connection. Right now, because it's just laying on the back of another laptop, we just get red lights. But when we're connected to our clients, we get green lights and we're ready to go, and then we select a protocol. We have 5 different protocols that we can choose from what's labeled as sensitive, mild, moderate, strong, or manual. Each one does a little bit different function with the offsets. The manual is something that we use with our athletes, and there are certain times to use it with even clinical cases. The strong bipolar offsets, again, I rarely use those, but we talk about it in our training of when it would be appropriate. So it comes down to moderate, mild, or sensitive, and by and large, you can do all of your sessions just on the mild setting. It is perfectly good, and it's not necessarily mild. It's a very powerful intervention for clinical patients. Then we get this screen right here, and that's a topographical map area. It'll take your client's raw EEGs down in this section here and then convert it into a topographical map. Now remember, right now my electrodes are laying on top of the laptop next to me. So these are not brain waves here that you're seeing, just noise in the room. But it takes the dominant frequency and then an offset, which is ever changing, changes every second or two so that the brain never gets used to it and then gives the signal back to the brain. Again, driven by the dominant frequency, but not the dominant frequency itself, just slightly offset from it. Then we return back to this screen, the pause between the stims, the stimulations, the conversations with the brain, and then continue on. And some of our clients take 2 or 3 of these stims, and some take much more, 20 or more. At the end of the session, we just simply hit session over, and I throw away the data. There's no reason to store it on my hard drive. I just want to know if the person's life's getting better. Exit the program, and that's kind of how we do the training.